And another interesting presentation was from Memorial Sloan Kettering and the Juno group on CAR-Ts. And so this is obviously a very exciting area in ALL. And they looked at the outcomes in their population with a relapsed ALL. And they probably had about, I think, 50 or 60 patients, so pretty good sized cohort. And what they showed is very dramatic difference in both toxicity and outcome based on the amount of disease going into the CAR-T. So in other words, patients who had more than 5% blasts, we already knew this from prior trials, that the more disease you have, that's related to the toxicity. It creates more toxicity, the higher disease burden. Toxicity is also related to the amount of T-cell expansion you get, but it's clearly related to the disease burden going in. What they showed is that if they divided the patients between those having less than 5% blasts, so generally kind of treated more for minimal residual disease positivity rather than frank disease, not only do they have much less toxicity, but that appears to be the group that has the long-term survival. Even if the patients who had bulk disease achieved MRD negativity, it wasn't durable. It only those patients had a survival in the order of about 6 months. So even though they were able to achieve very good responses, the tumor bulk had a huge impact on long-term outcomes. Ideally, of course, what we would like to do is, well, if that's true, go into an earlier population. The tricky part about that is that we still have a very significant toxicity profile with the CARs. About 25% of the patients will go to the ICU. So again, you have to weigh the risk-benefit versus going into an earlier population. But I think we're beginning to see data from some of the CAR trials where they're trying to intervene earlier in the toxicity. So what I mean by that is, we know that tocilizumab for the cytokine release syndromes that are severe is a very good treatment. And we know that steroids is a pretty good treatment for the neurotoxicity. Right now, the way the guidelines are, you don't really administer those agents until the toxicity is pretty entrenched. And I think the reason behind that was the idea that, well, if you're interfering with the cytokines by either using steroids or tocilizumab, maybe you're going to interfere with the efficacy. And so there was a lot of hesitation to bring these interventions in earlier because you might lose the efficacy. And these are generally very refractory patients where the risk-benefit is if you don't get a response, they are going to die. But there's emerging data, not just from the Sloan Kettering group, but other groups doing the CAR-Ts, that they don't seem to reduce the response rate. And if that's really the case, then we might be able to introduce some of these maneuvers earlier, not sort of waiting till the patient's on the way to the ICU. And if we can make the toxicity a lot more acceptable, then that will allow us to move into an earlier population. And maybe in an MRD population, we could actually look at using this strategy and not sending those patients to allogeneic stem cell transplant, which would be quite exciting. So that's my speculation on where some of the data is going, but I think that the data clearly show that the more disease bulk, the less the efficacy and the more the toxicity.